I would now like to welcome our first presenter, Dr. Song. Dr. Song is currently a medical oncologist and chair of the melanoma disease site at the Ottawa Hospital Cancer Centre. Her research interests include clinical trials of new cancer therapeutics, cancer survivorship, and medical education in relation to professional learning and assessment. She is the author of numerous oncology-related abstracts and articles, as well as a dedicated speaker and educator. Welcome, Dr. Song.
So thank you for that kind introduction. Good evening, everyone. As Mary introduced, that I'm a medical oncologist working at the Ottawa Hospital Cancer Centre, and I specialize in the treatment of melanoma or skin cancer and breast cancer. So thank you all for joining us tonight, and we really hope that you'll find these sessions or discussions informative. So I'm gonna advance. Okay, so what I would like to start is to give a brief review of melanoma incidence and some of the risk factors. As well, we'll move on to discuss some of the newer standard treatment options that are impacting patient survival. Lastly, we will talk about ongoing research that aimed at improving personalized treatment and why clinical trials are important and what's coming in the near future in the treatment landscape of melanoma. Okay, so as many of you are aware that sun damage to skin is a major risk factor for melanoma. Patients with certain skin type and family history of melanoma, as well as personal history of melanoma, are at increased risk for developing skin cancers. Those patients who are on immune suppression, so for example, someone had a transplant, immune suppressive medications, they're also at increased risk for developing skin cancer. There are also some genetic predisposition in certain family members that will lead to an increased risk for skin cancer as well. The actual cancer incidence in Canada, or we could say the number one cause of mortality in Canada is actually related to cancer. And nearly 1 in 2 Canadian is expected to have a diagnosis of cancer in their lifetime, and 1 in 4 Canadian may die from that cancer diagnosis. The good news is that since the late 1980s, the cancer mortality rate has been decreasing, partly due to early detection of many types of cancer, as well as more effective treatment options. So here I'm just showing you some of the cancer incidence. So as you can see, the incidence for some of the common type of cancer, such as breast cancer, colorectal cancer, even lung cancer, seems to be either staying steady or declining. But if you look at melanoma, so here on the bottom, the dotted line for the female incidence and the square, the blue line for male. So the incidence of melanoma is actually on the rise, partly due to, I think, more detection or screening that's available to patient, the aging population, as well as some of the environmental factors related to sun exposure or prior sun damage. So what can we do, right? Prevention is still the key. It is actually quite surprising to have the data on that 10% of the children are actually using sunscreen routinely, and at least many of them will have at least one sunburn per year. So we can do a lot better educating the younger generation. As well, I think there are other things that we can do, so avoiding sun tanning beds and covering up. So here, looking for shades when during the sunny days, and try not to burn, lots of sunscreen, putting adequate sunscreen for protection, knowing what to use, and educating your family members. The other thing would be early detection, right? Seeking medical attention if there are any new skin lesions that you've noted, and have your doctor take a look. If there is family history for skin cancer, probably doesn't hurt to sort of be vigilant and having a skin checkup on your own. So we talk about this as self-surveillance. So I think we do rely on patient themselves, as well as family physician and dermatologist, to do a great job in early detection. Some of the key words we see, the ABCDEs of detecting an early skin cancer. So A stands for asymmetry, B for border, C for color change, D for diameter, so a larger lesion or a lesion that increases in size. E for elevation or raised skin lesion, or evolution or change of a lesion. So dermatologists usually educate us and talk about the ugly duckling sign. So here, as you can see, if you stand far away from a patient and looking at the skin, so there's something that seems to just come into view, and then we can zoom in and see if that lesion is abnormal or trying to make a diagnosis. However, it is still somewhat difficult to make a diagnosis because melanoma has many faces. So the clinical presentation from each individual patient can be quite different. So here I'm just showing you a couple examples of skin lesions. So these are all melanomas. You can have a superficial spreading melanoma that's kind of a flat, almost like a freckle type of lesion. We see nodular melanoma that's usually raised, almost like a blister. Also amelanotic melanoma, so they're not usually pigmented lesions. Again, sometimes it could be a blood blister, or sometimes we're seen as a granuloma. Melanoma can show up soles of a patient's feet, and it could show up in mucosal membrane, as well as behind the eye or within the eye, so as an ocular melanoma diagnosis. So as you can see, the clinical presentation of a melanoma can be quite variable. So with further research, we actually have a better understanding of the molecular subtypes of melanoma. So some of the common mutations that we've identified, including the BRAF mutation, this is generally in patients with skin not due to chronic sun damage, but due to that intermittent intense sun damage. Often we see that in a younger individual. There are also melanomas from mucosal membrane. We can see a KIT mutation, as well as uveal melanoma. We often see a GNA11 a mutation. So these are some of the molecular targets that through clinical trials we're actually trying to develop newer treatment options for patients. So with everything being said, like any other cancer, the early we can make a diagnosis, the better long-term outcome would be for that particular patient. So it is actually a good sign that majority of the patients, so over 80% of patients, when they were diagnosed with melanoma, these are localized to the primary site, without lymph node metastases. And what are some of the treatment options? So for when we think about cancer, depending on the stage, right? So in the early stage setting, majority patient will have surgery. Sometimes they get offered radiation. With melanoma, the key systemic treatment, so treatment that goes through whether it's a pill to take or intravenous therapy, are focused on we call targeted therapy or immunotherapy. And there's always clinical trials ongoing for both early stage melanoma as well as more advanced stage melanoma. So I'll have some discussion regarding some of the treatment options today. So before I sort of go on with the story, I do want to show you this landmark meta-analysis, and some of you may have seen this graph. There was an old saying, from my mentors, and the researcher would say, if you really want to kill a new drug and try that in a melanoma disease, because nothing seems to have been working for patients with melanoma for many, many years. So this is through clinical trial testing different drugs. We're looking at 1 year survival of 25% up until about a decade ago. So then there has been significant advances over the last decade, right? We started with sort of on top of the graph, I'm showing you the development of checkpoint immunotherapy, including ipilimumab, pembrolizumab, and nivolumab. And then we're looking at clinical trials evaluating the combination of these immunotherapy. There's still ongoing treatment with newer checkpoint inhibitor combinations and how to sequence them. On the bottom of the graph, you will see targeted therapy. So there's vemurafenib as a BRAF inhibitor. Then we have dabrafenib, trametinib as a combination treatment. Then there's combination vemu with cobimetinib. So these are targeted therapy targeting someone with a BRAF mutation. And there's ongoing trials combining this with immunotherapy or with other type of treatment, trying to increase the overall survival for a particular patients with metastatic melanoma. So I think from patient perspective, really when there is a cancer diagnosis, we're hoping for the cure. And I think with melanoma, we have been very hopeful with some of the newer agents. So I'll briefly talk about the BRAF pathway. So here is a simple diagram showing you, if you think about this curvy line being the cellular membrane, usually normal cells will need an external stimulation. So almost think of the nutrients for that cell. Then the cells will start dividing and proliferate. However, in the setting of cancer, then with the mutation happening around the BRAF molecule, then cells will continue to proliferate or divide without that external stimulation. So treatment is actually aimed at blocking that mutation. So here we're looking at the combination of BRAF and MEK inhibitor, and there were several combinations through large randomized studies demonstrating improvement in both progression-free survival and overall survival. So here, I might just highlight, if you look at the overall survival at 2 years with these treatments, we've improved that to about 51%. If you remember that graph I showed you, at 1 year, only about 25% of people were surviving. So this is a big step up in terms of making an improvement in overall survival for patients with metastatic melanoma. However, the disadvantage of this drug is many patients will develop secondary resistance to the medication, meaning that the cancer will you'll have other mutations and then start to grow again. The advantage of these medications that they work really fast, and sometimes days to weeks. There's a high response rate when there is a presence of BRAF mutation. It does have activity in brain. Most of the toxicity were manageable. It is also an oral medication, so patient can take them at home. So can we do better than this? So here I'm showing you a model of a survival benefit. So we think that, with targeted therapy, many patients will respond, and then we shift that survival curve to the right. But can we increase the percentage even higher? And that was where we had high hopes for immune checkpoint inhibitor. And we weren't disappointed. So if we look at maybe this animation of cancer immunotherapy, so basically when someone have cancer, their immune system were suppressed by the chemicals that secreted by cancer cells. So our normal immune system, our host immune system cannot recognize cancer. So they were questioning, are you a friend or your enemy? When we put in the immune checkpoint inhibitor, then we are actually heightening the host immune system. So the individual patient's immune cells will recognize cancer and they will start to attack the cancer cells. And that's how we actually treat or get rid of these abnormal cells. Some of the key agents, including the CTLA-4 antibody. So in melanoma, the medication is called ipilimumab, and PD-1 blockade, including both pembrolizumab and nivolumab. And there are certainly lots of other newer anti-PD-1 agents, as well as CTLA-4 agents, becoming available for different solid tumor types. So this is the success story with long-term survival of ipilimumab demonstrated in melanoma. So when lots of the trial data were put together and we're looking at the overall survival of patient being treated with ipilimumab alone, I think the curve that's really meaningful is the long-term, the flattening of this curve. At around 20% of the patients will continue. So if they're stable, no disease progression at around 2 to 3 years, those patients, even without further treatment, they will continue to do well, even past the 5 or 7 year points. So it makes us as oncologists very excited, and we're actually thinking, are these patients being cured because of that treatment? Then that comes with, our famous Jamie Carter's surprise of a cancer turnaround, and he had metastatic melanoma with brain metastases, was treated with pembrolizumab. And so many patients were very keen on getting that newer agent. It is safer than ipilimumab. And recently, we actually had an update of long-term outcome for patient treated with pembro. And this is a survival based on the response at 24 weeks. So those patients, if they had a complete response, if you could see 60 months, majority of patients are still living either with or without cancer. For those patients, even if they had a stable disease, so the cancer was still there, or they had a partial response, over 60% of the patients still are alive at month 60. So this is, again, very exciting news, an exciting update from an immune checkpoint inhibitor. But moving along, so we have a CTLA-4 and we have our PD-1 inhibitor. So what about, we always talk about when you add, and is there synergy effect of the combination treatment? And that moves to our key or the landmark trial of Keynote 06, Checkmate 067, sorry. And this is a study that evaluated the combination immunotherapy of ipilimumab with nivolumab, and then compared to ipilimumab alone and also nivolumab by itself comparing to ipilimumab alone. And we recently, so about a month ago, had the 6.5-year outcome update from that clinical trial. So it is very exciting to see the flattening of that curve again. And as you can see here with the combination, so the top curve, the red curve showing progression-free survival, and the bottom one showing overall survival. So if we look at 72 months, 50% overall survival for the combination immunotherapy. So again, a very significant improvement from our historical data for melanoma patients. I think actually showing all the data, pictures will worth a million words. So here is actually a patient of mine we recently treated. She presented with very extensive disease involving lung, requiring oxygen, really was not feeling very well. We give her the combination immunotherapy, and that led to a complete response of the cancer spots in her lung. And hopefully she will be one of those long-term survivors when we continue with her follow-up. The other exciting thing about this combination is that if we look at patient who's alive and treatment-free at 6.5 years, so patient had their initial treatment 6 years ago, and what we see is that close to 80% of these patients, they're actually treatment-free, and they did not really have to receive other type of treatment. So this is very exciting because number one, if you can have a short-term treatment controlling the cancer and be able to carry on with your normal life, I think that would be great for someone with a diagnosis of metastatic melanoma. I think it does suggest improvement in overall survival as well as quality of life based on the current clinical trial data. Another point to make was the combination of ipilimumab and nivolumab is regarding the activity in brain. So we actually hear from Georgina Long, who is a melanoma specialist from Australia. She updated their trial using combination immunotherapy for brain metastases. And then you can see from here, the patient was treated with immunotherapy alone without any radiation. The brain lesion actually improved after treatment at 1 year. You really do not see anything abnormal. So, the potential benefit of this is if you don't need radiation, if you do not need surgery, it avoids potential long-term toxicity of cognitive changes. Sometimes radiation can induce radionecrosis or inflammation of the brain. So for those patients who doesn't need it, certainly will be able to reduce the treatment-related toxicity in that cohort of patients. And then from that trial, we look at 5-year outcomes in patient with brain metastases. So in the top curve, the yellow curve, really are in patient who have brain metastases, but they do not have symptoms, and they seem to do much better than the bottom curve, where actually patient with brain metastases, but they do have lots of symptoms requiring steroids. And I think based on this learning, we've suggested that it is important when someone with metastatic melanoma, we do need to screening patients for CNS or for brain metastases so we can do treatment early. And also, I think often the combination immunotherapy has been used upfront in patients with a newly diagnosed melanoma. So we are hoping we can prevent development of brain lesions from the beginning. However, why do we not give everyone this combination immunotherapy? And that really is related to toxicity, right? When you compare the orange column to the red column, so this is the immunotherapy with anti-PD-1 versus the combination immunotherapy. So the toxicity is 96%, meaning that almost every patient gets treated will experience some side effects. When we talk about severe side effects, then it's about 60%. So in these patients, either they will need to be hospitalized or they will need to have immune suppression, and that can impact on their quality of life. So we do have to select the right patient for the right treatment. There is some treatment-related death as well. So if someone or a patient is very frail and they've got other medical issues, then we do have to decide which would be the optimal treatment for that particular patients. And here, just to show you a diagram demonstrating immunotherapy checkpoint-related toxicity, it really could result in inflammation or or issues related to any parts of the body, right, head to toe. So people can have neurological symptoms. It could affect lung, heart, liver, kidney, or even joints or muscle, as well as bowel. So it's not a light therapy to go through. So I think whenever a patient being offered this type of therapy, we suggest ongoing monitoring, and also lots of patient educational materials. And patients do rely on support groups and their family to go through these type of therapy. So, when we look at a patient, so what is going through in my mind when I'm evaluating patients for treatment, right? So single agent may be for someone who does not have high disease burden, right? Maybe they have one nodule, they have one normal LDH level, which is a biochemical marker. They do not have brain metastases, and they, some of the patients may have other health issues, or they have autoimmune disease. We would worry about risk of developing immune therapy related toxicity. And sometimes it would be based on patient preference as well. For combination therapy, usually it's offered to patients who are healthier and maybe higher disease burden, and the patient preference will be taken into account when we are making the treatment decision. But that being said, I think we are still aiming for better options with newer treatment targets, and we're looking for safer options through ongoing clinical trials. So I'm going to change gear a little bit. So up until now, we talk about some of the standard options for metastatic melanoma. What about prevention treatment, right? So for patients after surgery for their initial diagnosis, if there's lymph node involvement, we would classify that as stage 3 melanoma. When there's no lymph node involvement but a thick primary, so sometimes we look at ulcerated lesion or over 2 millimeter or over 4 millimeter, these patients are still at high risk of developing a recurrence within that initial 5 years. And this is where we want to target to improve their outcome or lower the risk of recurrence. So in recent years, there has been several adjuvant or preventative clinical trials evaluated both immunotherapy and BRAF targeted treatment. And the good news is that we do have some positive trial data. So Keynote 054 compared pembrolizumab to placebo, demonstrating improvement in lowering the risk of cancer recurrence. When you look at Checkmate 238, this is to comparing nivolumab to ipilimumab, again, improvement in relapse or the disease recurrence rate. COMBI-AD is a trial that looked at the combination dabrafenib and trametinib. So it's a targeted therapy option for patients compared to placebo. And we are again seeing improvement in lowering the risk of recurrence. And long-term data hopefully will show improvement in survival as well. We're waiting for those data. So these are actually currently I think approved across the country as standard adjuvant treatment for those patients with high risk disease, especially stage 3 melanoma. So what's coming? And so this year, over the last few months, we've had several new studies. Perhaps one of the key study is the Keynote 716. This is looking at the comparison of pembrolizumab, so the PD-1 inhibitor, versus placebo. And it's actually evaluated in patients with high-risk stage 3 melanoma. So these would be thicker melanoma, but no lymph node involvement. And the trial data demonstrated recurrence-free survival when patients were treated with immunotherapy. So I think this will likely lead to a change in practice in the near future. Some of the physicians likely will be discussing the possibility of treatment in the patient population with high-risk stage 2. And however, so when I talk to a patient, when you have someone facing you who had surgery, the cancer is removed and they're cancer free, it's actually not a simple discussion when I review the potential treatment toxicities, because some of these will not be reversible, and there is always that small risk of dying related to cancer treatment itself. So, and that's actually a current problem with these prevention therapy is we don't really know which patient needs it and which patient doesn't need it. It's more based on the population evaluation. So some of the patient may never recur after surgery, whether they had treatment or not. And some patient, even if they get 1 year of treatment, may still recur. So we're actually improving that 20% of the patient by giving them their outcomes, by giving them the adjuvant or preventative treatment. But this strategy is, it is a lot of toxicity for many patients. It's also quite costly. Patient also need to come to clinic often. They have to go to their infusion treatment. So can we do better? And that lead to a lot of the newer concepts on neoadjuvant treatment. So why do we do this? With research, we know patients' their immune function is actually lowered during that surgical time. So if we introduce this immune stimulation early, perhaps we can actually prevent distant spread. It gave us an opportunity to look at treatment response, right? So we could look at if the cancer is shrinking before the patient went on to have surgery. And then we could do some biomarker studies. So looking at the tumor, doing some genetic evaluations, and then say, is this high risk? Is this low risk? Do we really need to give further treatment? So this is, I think, a very exciting approach, and that's being evaluated through many smaller clinical trials. One particular evaluation also looked at the differences between giving treatment after surgery or before surgery, and there seems to be a suggestion that if we give treatment before surgery, perhaps the long-term outcome is better than if we do it after. And then we also looked at the predictive value, right? So if someone had treatment before and they had a great response, either tumor shrank to a very minimum amount or it completely disappeared. And in those patients, even if they did not receive any treatment after surgery, the relapse-free survival was over 90%. Whereas those patients who didn't really respond to their pre-surgical treatment, their outcome is a lot poorer than the ones responded. So perhaps this is a group we need to target and give more treatment or more aggressive treatment after surgery. There's also clinical trials evaluating patient response and then using that response to decide on what type of surgery, right? Do we go and do a big lymph node dissection, which will result in increased lymphedema, maybe pain symptoms, and some people may have trouble with ambulation due to swelling of their legs or using their arms. So this is exciting, is that if we can guide the surgical procedure and minimizing the long-term toxicity of the patient, and that would certainly be practice changing. So here are some of the ideas about neoadjuvant. So giving systemic treatment before surgery is that we'll do treatment inpatient, we can palpate the lymph node, and we would do biopsies and perhaps doing some molecular studies. A patient will get their therapy over the next 6 to 8 weeks. And then they actually go on to have their surgery, and we use the data available to decide on what to do after the surgical procedure. So this is really still in clinical trials, but I do think in melanoma, this is an exciting approach for patients, both in terms of tailoring the treatment modality after surgery, as well as decreasing potential side effects for patients. And so this model is, if we know if the patient is high risk versus intermediate risk versus low risk, we can actually decide on treatment differently for that individual patients. Moving along, I wanted to quickly highlight some of the newer agents that's coming up over the recent months as well. One is a newer checkpoint inhibitor. It's a LAG-3, and that was evaluated in combination with immunotherapy nivolumab, comparing to a single agent. The combination demonstrated improvement in progression-free survival. And again, this may lead to a praxis change, and hopefully we'll hear more when long-term follow-up from this clinical trial is available. I think this combination, another thing about this combination is perhaps the grade 3-4, so the severe toxicity is less, about 40%, where we saw that being about 60% for a combination ipilimumab and nivolumab. Another agent is a pegylated interleukin-2 combining with nivolumab, again showing both a very promising progression-free survival benefit as well as overall survival benefit. So the idea is, these combination may result in better outcomes. The phase 3 trial is pending. Hopefully, we'll have more information in the next 1 to 2 years. Just to highlight a newer therapy for uveal melanoma. So this is a rare subtype of melanoma, and the medication, so tebentafusp, is actually the first agent being approved by FDA over 40 years for uveal melanoma, and it's demonstrating improvement in overall survival benefit. This is a bispecific protein, so it kind of helps to bring the cancer cells and the host immune cells together, so it makes the killing of the cancer cells more effective. So it targets the protein on the cancer cell and other protein on the immunocells. So this is, again, I think some of the centers were able to access this agent for patients with metastatic uveal melanoma. And I think when we talk about melanoma, I think there's a lot of excitement about tumor infiltrating lymphocytes. So just a little bit information on lifileucel. This is a tumor infiltrating lymphocyte therapy. So usually how it's done is patient's own tumor tissue will be biopsied and then generating some of the say young lymphocytes that can potentially target tumors, and patient receives some chemotherapy, then they get the TIL infusion and maybe some immune cytokine treatment, usually given in hospital. So this agent ended up showing a significant overall response in patients. So 80% of patients actually see tumor reduction. So just to kind of highlight, these are the patient, actually most of them received multiple lines of treatment before, so they failed combination immunotherapy, maybe targeted therapy, so they've had prior therapy and things were not working, and they go on to the TIL therapy and showing some benefit. So again, exciting news. And I think maybe just a quick word on some of the sequencing therapy, right? So we have targeted treatment, we have immunotherapy. So can we sequence them? Do we do one type for a bit, for a short period of time, and then moving on to the next? How do we combine them? And I think just about, maybe 1 to 2 days ago, we have a report from the DREAM-6 trial that looked at giving patient targeted therapy, then followed by immunotherapy, or just the immunotherapy first, and then following targeted therapy after. I think the trial suggesting that perhaps starting with the immunotherapy is the better way, demonstrating a better overall survival in patients with a BRAF mutation. But lots of other options still to be reported. I think this is still an area we need more data. So finally, I think I wanted to highlight, I talked to you about many clinical trials, and I'm very proud that I think for all these practice-changing landmark trials, Canadians have played an important role in the development of these therapy. And we were involved in almost all the key landmark trials. Currently, the Canadian Cancer Clinical Trial Group is actively working on developing new ideas, optimizing the management for melanoma. We are looking at options of new adjuvant treatment or combination approach, looking at evaluation of biomarkers. There are some trial ideas looking at patients with rare mutations or subtypes of melanoma, for example, patient with an NRAS mutation or with a atypical BRAF mutation. We're also looking at options to better manage patients with brain metastases. And here as a Canadian, we also are very, I think our patient outcome or patient-reported toxicity is very important. We're looking at duration of treatment. So, would everyone need 2 years or 5 years of treatment, or can we shorten some of the patients' therapy if they responded very well initially, since we've had lots of data suggesting, at 12 weeks or 24 weeks, if you had a complete response, you likely will do well long term. So maybe not prolonged therapy, which can result in more treatment-related toxicities. So here just a schematic or a diagram showing you how many combinations of chemotherapy or immunotherapy are out there. So I think as an oncologist and for our patient, I'm very excited of, what are the things that's potentially coming. And what we're hoping for is with all these combinations or different checkpoint blockades, we will be able to continue to improve patient survival with the inpatient with diagnosis of metastatic melanoma. So last one, I think all of you are here. I think we do need patient like you who cares about what we do and cares about treatment options. And I think without you, nothing is going to get better.